Chapter 30 is the eye, ear, nose, throat, and not mouth, but oral cavity. That's how they say it. They don't say mouth anywhere in the chapter, which is pretty cool. Eyes, ears, nose, throat, oral cavity. That's what we're talking about. So, like always in this book, the chapter begins with some A and P. So they give you a nice breakdown at the beginning with the layout of each of these structures. So a good breakdown of the eye and the eyeball, the ear, um, and then into the nose, mouth. It even gives you a breakdown of all of your teeth. So if you don't know which teeth are which, you can learn that on page 710. So once you have a good understanding of the anatomy part of this chapter, then we can get into the disorders and the problems that we're going to probably be facing. As far as the eyes go, there's a few things that the eyes can tell us as we look into them, part of our assessment. Some of the things that we're looking for when we assess eyes. Anybody want to jump in here and give me what we're looking for? Say that again.
I don't know if he meant to do that.
Oh, was that a radio?
Yeah. I guess for eyes, you're looking at like pupils. Are they dilated or are they pinpoint? Are they reactive to light? Are they bloodshot? Is there anything in it? That sort of stuff. Can they follow your finger?
Okay. So we look at the pupils, dilated versus pinpoint. We also want to look at, are they both the same? Because one being dilated and one being pinpoint is a problem for us. Reactive to light, a good thing. So we want to see that when we shine light, they should get smaller, take the light away, get bigger, and all that would result in normal activity. Bloodshot eyes could be a couple of indicators. One being they might have some stuff in their eye. So they could have some foreign substance, dust, dirt, debris. Or what's another indicator of bloodshot eyes?
Drugs.
Yeah. What kind? Any particular kind of drugs?
Well, there's marijuana.
Marijuana for sure.
And then stimulants can lead to sleep deprivation, and sleep deprivation can cause your eyes to be bloodshot.
Right. So a lot of these people, if they are doing these recreational things, they know this. Most of them are pretty in tune to it, and they know all of these things. So you'll see them with some eye drops. They probably have like Visine or something available to kind of help keep that down and under control, so people don't notice right away. So yeah, but if they don't get to that point, then the bloodshot eyes could mean some dirt and debris issues, but it also could mean some recreational drug activity to us. What else about the white of the eyes, the white parts, the sclera are we looking at? What if it's a color other than white or bloodshot?
Be yellow.
Yeah, what's that indicating?
Isn't that like an early sign of jaundice?
Right. Yeah. So that's where we can see some jaundice in that part of the eye. So always good to take a look at those and see that. And that would indicate to us that there may be some liver issues in these patients. So, and then the shape of the eye, right? Because we talked about how the eyes are shaped when we were back in the endocrine system, and some of the endocrine issues can affect the shape of the eyeballs themselves. So those bulging bug eyes would be an indicator that they've got some type of endocrine issues, mostly overactive thyroid. So a lot of information coming just from looking at eyeballs, looking at the eyes. We can get a quick assessment of the eyes, but it could give a lot of telltales for us.
What about glaucoma? That does something with the eyes, right?
It changes the shape of the pupil. They've got some, and if you look into it with those scopes that the eye doctors have, they can actually see those shapes in there. So
Okay.
it's a pressure deal that's causing it. It's a pressure change that causes glaucoma, which is why they treat it with. That's why the joke is you can treat glaucoma with what?
I have no clue.
Marijuana. You know, all of those people that when they talk about marijuana, they talk about getting the medical marijuana for glaucoma, because glaucoma is an increased pressure in the eye, and so the marijuana is supposed to relax people and hopefully, I guess, in turn reduce that pressure. So that's the treatment side of it. So if you run across people that are on medical marijuana, that's one of the more likely reasons for it. Other reasons would be cancer, and I think cancer and glaucoma are probably the two bigger ones. And then chronic pain probably. But I haven't seen any medical marijuana stuff in this area, so I know the state of North Carolina has not done what these other states have done by legalizing it or decriminalizing it, but I haven't seen people that have or are readily admitting to these medical marijuana issues. Is anybody else running across that?
No, not around here.
No, I haven't seen any. I mean, there's plenty of marijuana, but I haven't seen any on the medical side.
Right.
Derek, is anybody in Elizabeth City admitting to medical marijuana? Probably not. All right. So, but yeah, that's the short of glaucoma. As far as issues with the eyes, there are some infections that can occur. Most popular infection we refer to as pink eye. Conjunctivitis is what it is, and it is a infection, highly contagious, and spreads rapidly, but usually results with oozing out of the eyes, and they're probably going to be a bloodshot red or pink color, which is where the pink eye name comes from. So if you're seeing that, then watch out, wash your hands, don't sleep next to these people because it will spread. Anybody ever had it?
Yeah, when I was younger.
Yeah. Comes across, yeah, I mean, it hits people at different ages, at different age groups for different reasons. There's the old joke of wiping your butt with somebody's pillow, and it'll give them pink eye when they sleep on it and that sort of thing. So just watch out for that. As kids, it could be some kind of allergy thing or just a little bacteria or fungus that they run across. But it does affect all age groups. So adults get it just like children do. Um, the thing about it is hygiene and managing it once you have it. So highly contagious. So wash your hands, wash your pillows, the linens, that sort of stuff, and then take the medicines and contain it, control it. But it will, if not careful, it will spread like crazy. So um, the book talks also about having a sty. That's just a clogged duct. And so here, we'll get her in here. A clogged duct. And typically the easy way to fix that is warm compresses on it, which will promote drainage. And in the irritated, infected part of it, it's gonna swell up. It's gonna be right in the eyelid, along the eyelashes, and it'll be typically on the bottom set of eyelashes. So that thing will turn red. It'll swell. It'll look terrible. It could affect their vision if it gets big and bad enough. But really the fix for it, they do have some medication for it. You can buy over the counter stuff, but warm compresses will work fine to promote drainage, and that'll help it. Hmm. Does anybody have anything they want to add to the eyes?
Nothing I can think of.
No, I mean, they can give us some indicators for trauma, and we'll talk about that more in the trauma section. But um, with the reactiveness or the unequalness between them, as far as the assessment goes in the non-trauma world, then it can clue us into some medical problems with thyroid issues or liver problems. It can also give us some lifestyle or behavioral indicators if we're suspecting, some types of drug usage or that sort of stuff. So a lot of indicators with the eyes, and really, there's not a lot of treatments for the eyes as far as we're concerned. If we do have to flush them, um, we would try to flush from the inside out. So start closer to the nose and flush towards the outside if you're flushing. I will tell you that if you can hook a nasal cannula up to some fluid and tape it down right across the bridge of their nose, if you're flushing both sets, that works great. Or you can tape it so that it'll flush one eye out as opposed to both. But nasal cannulas do work well to flush eyes. All right, we'll move on to the ears. If nobody has any more with the eyes, ears, again, you've got your anatomy pictures at the beginning of the chapter, which shows you all of the ear anatomy, the ear canal, the drums, the membranes, all of those things. A couple of issues with the ear, one being infections and the other being inflammation. Um, in the world of living near the water, especially in the summertime, we have a lot of people that are in the water a lot with pools and open water. Um, there is a thing called swimmer's ear, um, inflammation or infection of the ear canal. They have some over the counter medications that help with this. Typical signs and symptoms are going to be pain. There may be some water that's trapped in there because of ear wax, or so just eventually, when this flares up, the general symptom is going to be pain. Um, Not really a lot for us to do with it. They do have over the counter medication. They also have some prescription stuff that'll help with the drainage and the pain and the inflammation. So it's just a general feeling of bad for that person. Their ear is hurting, they're miserable, and it could affect their hearing some. They may feel like they can't hear as well, or it's clogged up. So just be aware of that. And if you're much into swimming or you've been in the water a lot, chances are you may have had this in your younger years. Um, but that's the one thing. The biggest problem with our ears is what we refer to as vertigo. Somebody want to take a stab at explaining vertigo to me and what we can do about it?
Isn't it just like a fluid imbalance in the ears?
Fluid imbalance in the ears.
Like messes with your equilibrium?
It does.
I
It's
don't know if it's any more technical than that.
it will throw off your equilibrium, your inner ear fluid. So people with vertigo are going to feel off balance. They may feel dizzy and nauseous. They may tell you that the room is spinning. Um, in in severe cases, I've seen people laying on the floor and they can't get up off of the floor. Um, if they try to pick their head up, they get nauseous and vomit. So watch out for that. But yeah, vertigo is a terrible, terrible way to live. It's like all of the effects of drunk without drinking. So you got all the bad and none of the good. What do we do for them? Any ideas?
We can turn the lights down for them and lay them back, not too far back, because that makes them dizzier. But keep the lighting low.
Okay. Low lighting, lay them back. What else?
In some cases, depending on the vital signs, we may be able to give them a KVO bolus of fluid. Well, KVO fluids.
KBO fluids. Nausea, vomiting is a big deal here. We really at this level don't have nausea, vomiting control. So if you have the availability to get that from your higher level ALS, then that would be great. If not, you're going to have to transport these people as is. So be prepared to deal with nausea and vomiting along the way. Make sure the convenience bags are handy, because you'll probably be needing those as you start bouncing down the road There is some over-the-counter medications that help with vertigo. The generic drug is meclizine, and you guys probably know it more by the brand name of Dramamine. It's a motion sickness type of thing. So people that are not used to being in boats that are going out on the water for trips, maybe on a cruise or out on a fishing trip for the day, they'll take that stuff to help with the seasickness. So it also helps with the vertigo. So that's an over-the-counter thing they can buy. You can get prescription meclizine as well. So if you know you have it or have a history of it, these folks probably have something from their doctors. But for us, it's not a thing that we carry. So if you can't get your nausea, vomiting control from a medic, then you're probably just going to have to be prepared with the puke for the ride. So keep your bags there, keep them cool, dark, laid back, resting as comfortably as possible. If you want to start an IV, KVO, I understand if they've been vomiting a lot, you can also justify dehydration and run a little fluid in them, but which may help them feel a little better. But as far as a treatment that's going to stop this, we just don't have it.
I feel like riding in the back of the ambulance probably won't help at all.
Nope, it sure won't. It's actually the one place where I get motion sickness. So if I have to ride in the back of an ambulance for a long trip, then by the time I get where we're going, I'm ready to puke in a lot of cases. So so for a patient that's not used to it, it's probably not going to help one bit. We don't usually see a lot of cases where there's any kind of short-term hearing loss. In the trauma world, could take a blow to the head or to the side of the head that could cause like tinnitus or something to that extent, but we don't usually deal with the fact that they've lost all of their hearing completely. So tinnitus is that ringing in the ears. A lot of people have it if they've been exposed to loud noise for a period of time, and they're usually in their work life, their career. Most people that get out of the military with some amount of disability because of tinnitus. So it may be worth, if they complain about that, then it may be worth checking into in your assessment about their past history, if what kind of work they did, or were they active military, around aircraft. If you've been around aircraft a lot, you may have this. It's just, loud noises, loud machinery for long times. So you can check into that, but really we just don't have any kind of fixes for these things. But it's good assessment for you. It's good things to document and relay along the way. However, it's not going to do anything for our treatment plan for most of these patients. What about the nose? Number one problem we get called for the nose.
Epistaxis.
Okay. That's the big word. So we get nosebleeds. We get called for those in a lot of cases, people are confused about what to do and how to slow it or stop it. So it's good for us to be able to provide them with accurate information and good technique here with the nosebleeds. So we do have some things we can do for these that we can work on and get it to stop. First and foremost, we use direct pressure. So pinch the nose, right? Does the head go forward or backwards?
Forward.
Forwards. Pinch the nose, lean forwards. This causes a stopping point, which will hopefully provide an area for a clot to form, and it can stop this off. What medication can we use to help with these nosebleeds to stop them?
Nasal spray. Nasal spray.
What kind?
Afrin.
Afrin. Okay. What's the other name? Somebody give me the big word. Come on. I know you got it in you.
Gotta go back to my basic drug cards. I don't remember.
Yeah, you better go back to your drug cards or start Googling faster than you're Googling.
Looks like xylometazoline. Oh no, it says it was developed from xylometazoline, so I don't know.
Yeah, it's should be oxymetazoline.
Ah,
All right. So that's the generic name, Afrin. The brand name that we know is nasal spray. It has constriction properties. So vessel constrictions is what's going to happen. So we put a couple of sprays up each nostril, and hopefully that will help constrict the vessels and promote clotting, as well as the direct pressure and leaning forward. One more thing we can do to slow stuff down and hopefully stop this bleed.
You can pack it.
Okay, two more things we can do.
ice pack.
Yeah, ice pack. So we can put cold on it, because cold also promotes constriction. So if you have cold packs or ice that you can apply to the face and around the nose, then that's great while you maintain that pinched off nose and leaning forward. Packing is a typical thing. They like to do that in the hospital. It's also becoming I guess maybe a little more popular in the field with this Stop the Bleed campaign, now that they're packing wounds and things like that. So shoving a little material up there to help block this thing off. And some people like to use tampons. They say they work well, about the right size, and they go up there as far a rolling up gauze, things like that. So sounds like a lot of fun. Should have a good time with it. What's the complication and the problems with nosebleeds?
If it's bad, it can compromise the airway.
Yeah, we can run into airway issues once we start our process of trying to stop the bleeding. If it's not coming out of the nose anymore, where is it going if it's still bleeding?
Down the throat.
Yeah. So blood going down into the stomach could cause some irritation there, which may lead again to nausea and vomiting. So watch out for that. And then if they do vomit, expect it to be a lot of blood when they do it. So suction could be important here, managing the airway, watching out for nausea and vomiting. But taking these techniques, we do have a few techniques here for managing nosebleeds. So hopefully you can make some progress and get that thing to stop bleeding, or at least slow down. Occasionally there may be a foreign body in the nose. Little trick kids like to play is see what they can shove in their orifices. So with the smaller ones, it's typically a reflex. They put stuff in their mouth. This would be a little bit older age kids, maybe in the 1, 2, 3-year-old category, where they like to shove little like army men and Matchbox cars up their nose to see what happens, and then that stuff gets stuck and they can't get it out. So watch out for that. We may be able to help with the airway tools. So you can try getting your scope out and looking. You can try McGill forceps if you can reach it and not do any more damage and slide it out. And if not, then transport them with the cautions of maintaining airway, suctioning, and comfort, and let the doctors have a try at it. In some cases, it may take a little sedation to relax them enough to be able to work whatever they've shoved up there out. But, raisins or gummy bears or something. But if you can grab it, tweezers or forceps or something like that, then if it'll slide out, then by all means. And if not, just manage airway stuff. That brings us to the oral cavity, which is the end of the chapter. So this is all mouth issues. Where do these people need to go if they have mouth issues, most likely?
Dentist.
Yeah, they probably need to go to the dentist. So why are they calling the ambulance? Usually because it's the middle of the night, or it's the weekend, or it's some time that the dentist is not open. And
Or they don't have insurance.
Or they don't have insurance. And what does the dentist like to do? Get paid, usually up front. So they'll call us. We'll take them to the ER, which is not appropriate. And the doctors will most likely give them pain medicine or antibiotics to help with infections like abscesses and that sort of thing, cavities that are causing pain. That stuff where typically what they need is to go to the dentist, either have the tooth pulled or a root canal or something like that, which will cost thousands of dollars. And they don't get to do that. So for us, the treatments are very limited and simple. We can justify IVs for these people just on anticipated clinical outcome. We know they need pain management, but we can't really do much for them. And then we're figuring they're probably going to need antibiotics, because usually it's an infection that's causing the pain. And then from there, it's just the supportive care thing to transport them. Again, we'll talk about trauma in the trauma section, but mouth trauma is a different thing. If the tooth has been knocked out because of trauma, we'll deal with that differently. But if it's just a medical issue or tooth issue from infection, something to that effect, and then we're very limited on what we can do for them. There is one disease to talk about here, which is a mouth infection that we refer to as diphtheria. Somebody asked me about Tdap too. Was it somebody in this class that asked me about Tdap recently?
Yeah, it was me.
It was about why we're getting Tdap so often. But diphtheria was one of those things. It kind of falls into the measles category and all these other things. One of those things that we had a pretty good handle on and pretty good control of with vaccinations until all the tree huggers stopped vaccinating their kids because they were afraid they were going to become autistic for some reason. And they think every vaccination is going to make them that way. So since kids don't get vaccinated anymore like they used to, diphtheria is one of those things that is making a nice comeback. So we don't want to get in contact with anything from these people fluid wise, respiratory droplets. So anything running out of their nose or mouth is contagious and can be problematic for us, which is the reason, and again, another reason why we're doing Tdap vaccinations, and they're doing Tdap measurements when you do your annual OMSEP physical to make sure that you haven't contracted anything because of your hazardous line of work. So I think they recommend in about every 5 years or so now that a Tdap booster be given. So they'll check that in your blood levels, and then you can get your Tdap booster now. All right, what else? Anybody got anything they want to add to the eyes, ears, nose, throat, mouth, every opening in the head? No questions? Again, they use a lot of nice formal words in that chapter, so make sure that you're reading, studying those highlighted, bold-faced words, because they'll ask you what they actually mean, and that's a simple test question for the meaning of those bold-faced words. So make sure that terminology is not slipping past you. Chapter 31 goes into mental illness and behavioral emergencies. So these are all of our psych patients, all of our potential psych patients, all of the ones that have to be babysitted and restrained, those types of things. Always good to know. Most important with this is going to be your safety. So if you're not knowingly going into this situation based on dispatch information, hopefully it won't take you long to figure out once you get there, and that you can get into a position where you are as safe as can be. The best way to deal with these folks is if they are unstable and uncooperative when you are on scene. You need to make sure that they don't get between you and the exit. So you need to manage that part of it. and you need to keep yourself in a position where you can exit and exit in a hurry should the situation deteriorate. So keep that in mind. Be aware of your surroundings. Don't hesitate to call for additional resources because this is going to be your saving grace. And then good luck trying to deal with these folks. The assessment should try to figure out, number one, what's going on with them, what kind of history that they have, what medications they're on. If you can answer these sample questions, you should probably get a good idea of what's happening. But what type of medical conditions can mimic these behavioral or mental illness issues and present
Brain bleeds.
the same way? So Derek says brain bleeds can make these patients look like they're mentally ill or psychotic, and that is true. What else?
UTI, altered mental status.
Okay, UTIs, sepsis type things, altered mental status,
Blood sugar.
blood sugar. That can alter mental status as well. That can make low blood sugars can make people agitated, irritated, and combative. Anything else? So, I mean, very quickly, we just came up with a few reasons why they could be acting this way that has nothing to do with mental illness.
Seizures.
Seizures.
Yep.
So our assessment is important here to figure out whether it's mental illness or something else. And that's going to be the key. So one of the quick things that'll help us is if you can find medications. If they have their medications there, you can find them. You can look at the medications and find out what they're taking or supposed to be taking, and see if it falls into this list. Your book gives you a short list of antidepressants, antipsychotics, and then some other medications that are used to treat mental illness. So if you recognize those, then you would know that this person probably does have a mental illness if you see those medications laying around versus one of these other things. And it doesn't mean that those other things can be discounted right away, but we just need to check into it and try to figure some things out. Typically, once these people get ramped up, how is this going to end for us?
Law enforcement.
Okay. Mark says law enforcement. How anxious is law enforcement going to be to get involved in these things?
They're not going to be.
Yeah. They typically don't want to get involved because then they have to take over and they're responsible for these folks. They can't, if they arrest them or restrain them, then they're in their custody from there on out, which becomes a burden to them and not something they want to do. So they don't want to get involved until the very end when they don't have a choice. They would rather these people go willingly with us, which most of the time these people just don't really want to do. So so then we're kind of left in a conundrum. So we can do some things. Of course, you need to get some help here. We can do some things. Can we restrain these folks?
When you say, can you restrain them, you mean like, and we put them on a stretcher and strap them in?
Mm-hmm. We can put them on a stretcher and strap them in. Can we put them on a stretcher and tie them down?
No.
No?
Yeah.
Yeah.
As long as you don't harm yourself or the other person.
Okay.
That's not ethical though.
What has to be in place for you to be able to physically restrain these people?
Or order from medical direction.
Do you guys have standing orders for restraints?
I don't know, to be honest.
Okay. That would be something that would you guys would probably want to look into if you're not sure if your agency has a standing order for that. If you're not sure, and probably even if you do, it wouldn't be a bad idea, as Demetrius said, to contact medical control, give them the rundown of what's happening, and see if they agree with that, and they can get behind that and back you with it. According to the textbook, and this is interesting, how many people does it take to physically restrain a patient? Do you know how many people it takes?
3.
5, I think.
Yeah, the textbook says 5. You need 5 people to physically restrain someone. So how they come up with that number is 4 people will be doing the restraining, and 1 person will actually be either hooking them up or tying them down. So depending on the restraints that you're using. So 4 people, that's 1 for each extremity. So 1 person per arm, 1 person per leg, and all 4 in a coordinated effort are supposed to basically take this person down and restrain them at one time. And then the 5th person is going to do the connections, which is either making a restraint or using a commercial restraint, and either and hooking it to the stretcher. So according to the text, 5 people you need, and then their caution is not to remove the restraints and not to bargain with the patient about the restraints. If you get to this point of restraining patients because they're out of control or they are a harm to themselves or someone else, then follow through with it, do it. And typically what will happen is once they are restrained, then we're probably going to follow that up with some chemical restraining as well, which is going to require your medics to be on scene so that they can do some sedations. They'll pump some little cocktails into them and get them hopefully to go night-night for the trip. So we've talked about that before. Some of the medications that they use, one of them is your Benadryl that you have because of its sleep properties. And then a couple of the other medic stuff. They've got some Haldol and Ativan and Versed and different things that they can use to calm patients down and kind of sedate them and take them to their happy place. So that's a lot of people, a lot of resources, and a lot of things going on, and that's probably worst case scenario. So right before I say that would be next to worst case scenario, right before the cops have to get involved and they'll start taking them down, and they've got a whole different set of techniques than what we do. So our method and preferred placement of this person is going to be supine. So put them on their back on the stretcher. If we're restraining them, and we're only restraining the 4 extremities. You don't restrain the head. You don't restrain the chest. You can put the seatbelts on accordingly, like they would be, but as far as tying things down to the stretcher and making them physically restrained, it would be just the 4 extremities. prefer leather restraints because they don't tighten as they move, and they don't loosen, and they don't stretch, and they don't cut into their skin and that sort of stuff. So leather restraints are preferred. However, if you don't have the commercial leather restraints, then you can make them with triangle bandages, sheets, those types of things. You can do that, but you better make sure that if you're tying those things, you better be tying them well. And if you're one of the 4 people that are doing the restraining, you better hold on, because people are a lot stronger than you think. Kids, especially, the kids will surprise you with their strength, trying to hold them down. So your chapter's got a whole lot of information about different mental illnesses. It talks about bipolar issues, schizophrenia, mood disorders, eating disorders. There's a ton of things in there to talk about. Substance abuse and withdrawal. So alcohol is a big one, and we see that a bit. We also get into the more serious drugs, and then the big one at the end of the chapter is suicide. And so just to touch on this for a minute, we all have I'm sure you've heard the rule of thumb from EMS people is that if they tell us they want to kill themselves, they're not serious. The serious people do it without telling us, right? You guys heard that?
Yeah.
Oh yeah.
Yeah, probably even said it a time or two. I know I have. So it's not actually true, although maybe statistically speaking it could be in the more accurate category. But just because they tell us that they're going to do it, we think they just want attention, and they're not serious. However, sometimes they are, and they do it. So suicide is a big deal. I don't know if you guys are familiar with the occupation, and it's actually an emergency services occupation that has a real increase in suicides right now. Anybody familiar?
What was that question again?
The occupation that has a tremendous increase in suicides currently.
Is it licensed clinical social workers?
No, it's in the emergency service world. It's actually firefighters. Right now, firefighters are experiencing a severe increase in suicides. And they're attributing this to PTSD, and that's becoming a big mental health issue right now. PTSD from the military, and PTSD is not only from the military, but they're seeing this in any line of work. So they're attributing the things that we see in the line of our work in the fire and the EMS and police world as a PTSD issue also. So that is something that's coming down the line. So you may be hearing more and more about it, more and more to deal with it. These are the people that are dangerous. The PTSD people are the ones that they're serious, they're dangerous, they're unstable, and they need some help. what the answer is to fix these folks, I really don't know. Anybody have any thoughts on it? Um, if you think of anything with PTSD, it's good to discuss. You can watch these things in your partners. Watch these events. They do have peer groups. They have discussions, things like that that you can get through. But typically, after traumatic events, we all have to go through some type of debriefing to help diffuse these situations. But in a lot of cases, these folks kind of slowly spiral downward and then eventually get to their limit. That's one of my philosophies in life. I say people have two things. All people have two things, and you might not know exactly what they are, but you'll know when you get to them. So
Beeman 355, Beeman 355.
The two things is everybody has a price and a limit, and you may not know what they are right now, but when you reach them, you will. So, but that limit is what they hit and what they can deal with, and we'll figure out what their problem is. If you guys will stand by just for a quick second. All right. So back with you. So just be aware of that. I don't have any good data on EMS workers specifically, but for some reason in the last couple years on the fire side, firefighters have been going nuts. So it must be a crazy world out there. What else? Anything else from the mental health side of things? It's going to take some time to work with these folks. I promise you, if you go to these calls and if they're not cooperative, you're probably, unless things deteriorate rapidly, you're probably going to be on scene for a little while, trying to work with these people and talk to them and convince them that going with you to the hospital is in their best interest and they need to get some help. In a lot of cases, we may not even do anything to them other than give them a ride and get them there, but at least we get them there so that the doctors and the staff can work with them and figure something out. So in the extreme cases, we may need a lot of resources on scene to physically take these people down and restrain them, sedate them, and transport them involuntarily. So it could go for a little bit. It could get hairy. Again, your safety is paramount. So your positioning on the scene, your physical positioning in the house or in the structure, be aware of the surroundings. We don't know what's there, what's not there. So law enforcement on scene is probably a good idea. Although I don't know how much faith you put in some of them. Some of the law enforcement I've seen around here doesn't seem to be quite on their ball. So good luck with that. And I don't know what else to tell you. What else? Anybody have anything on these folks? All right. So let's get into the last chapter then. It's toxicology emergencies. So these are all the toxins that are out there in the world. There's a ton of them, and if we have suspected toxins, who do we want to call?
Poison control.
Okay, good. I was gonna say, don't say ghost.
I'm
Yes.
too young for that.
Yeah, there you go. Poison control. That's the people we want to call. What's the phone number? Anybody know?
I got 1-800-222-1222.
That's it. It's a standard number across the country. So it doesn't matter where you are, you can pick up a phone and dial that number and you will get a poison control center. There are 55 poison control centers in the United States. So they're spread out geographically, and I believe I've called them a couple times, and I want to say that the one that you reach from this area is out near Charlotte. So I think that one covers us and probably a little bit of some of those other states around us. But that's who you'll get. If you have never called poison control before, they will ask you about 187 questions about what you're calling about. So if you're going to call them, be prepared and have as much information as possible, as much information about the substance as you can get, as much information about the patient as you can get, and then they'll direct you from there as to what their recommendations are. You can also call medical control, but the information you get from medical control may be more generic than what you get from poison control. So in toxic atmospheres, who's the first people that that we notice having problems?
Drug addicts.
Drug addicts.
Kids getting into bleach and stuff underneath the cabinets.
Yeah. If there's an issue in the atmosphere as far as something respiratory or anything like that, I would encourage you to let the police go first. We can use them as a meter, since until the fire department gets there with their atmospheric meters, let the cops go first, and that way, if they start coughing and hacking and falling out, you'll know. Don't go in there. Use them as best you can. They're like the canaries. But watch out for those atmospheric issues. There was a carbon monoxide issue that they had in Edenton one time. They ended up transporting about 15 patients to a hyperbaric chamber for carbon monoxide poisoning. They had a couple EMS workers that they had to treat for it. And after that incident, they actually put 4 gas monitors in the jump bags on the ambulances for them. Because of that, they went into that atmosphere unknowing that there was an issue, and it actually took them a few hours and several EMS calls to different locations before they clued in what was going on and what the issue was. And it turned out to be a carbon monoxide issue at a restaurant. So, but they ran a couple calls in other locations, and then they finally clued in that all of those people worked at that restaurant. So then they were able to investigate and determine the issue. But they ended up sending about 15 people to the hyperbaric chamber to get treatment for carbon monoxide. So these things do happen, and they can be problematic for you. So carbon monoxide is a big one. How does carbon monoxide occur in the atmosphere?
Through exhaust,
Through exhaust? From what?
like
In
an
com-
automobile or a machine.
Okay.
It's incomplete combustion.
Okay. So it comes from the process of burning. So there has to be a fuel fire of some sort, and then incomplete combustion. Usually it's a malfunction. If it's equipment, it's malfunction that causes this. How do we know that there's carbon monoxide there?
You got to
hard to
call for
tell.
additional resources. I'm sorry,
Call-
Mark, go ahead.
All I said is it's hard to tell unless someone starts to have altered mental status for no reason.
Okay, hard to tell.
Sometimes you can
Demetrius said,
smell it.
what's that?
Sometimes you can smell it.
No, you can't smell it.
Can't you smell it?
You cannot smell carbon monoxide. You might smell the burning process,
Oh, okay.
but you cannot smell carbon monoxide. You can't see it, you can't smell it, you can't taste it. So the only way to know it's there is you have to measure it. And like you said, call for additional resources. Typically, your fire departments are carrying meters that can measure it. Also, the gas companies are doing that. So if you have a gas company that you can get in touch with, or a fire department, they should be able to monitor these things. But there has to be some clues that are going to steer you in that direction. So typically it's going to be, number one, you have to know that there's fuel fired items in that area, in that space, and that and then you have to have some kind of reason to suspect that that's the cause, which is meaning we're going to have a patient of some sort. So what do carbon monoxide patients look like?
Pale and diaphoretic.
What else?
They're going to be lethargic with like classic signs of hypoxia.
Okay. So hypoxic, lethargic, pale. What else?
Altered.
Altered.
You won't be able to tell by pulse ox.
Nope. No, and you really won't confirm it until they start monitoring the air and measuring it. And once it's there, you'll know. What's the treatment for it?
Oxygen.
Yes, oxygen, and lots of it. So put them on a non-rebreather, give them oxygen, and transport them. And in the cases in Eatonton, they were severe enough that they ended up taking those folks and flying them up to Duke, to the hyperbaric chamber, where they can put them in that chamber and take them below pressure, and that pressure change knocks the carbon monoxide off of the red blood cells and allows the oxygen to attach. Oxygen and carbon monoxide molecularly are very similar as far as weight and structure. And so when the carbon monoxide bonds to the red blood cells, the oxygen cannot, but it's also not strong enough to knock it off. So that's what that pressure does in the hyperbaric chamber. It knocks the carbon monoxide off and lets the oxygen reattach, and they start doing better. So that's what happens there. You may also hear people have like a cherry red skin color from carbon monoxide poisoning. That is true, but I will tell you it's a very late sign. So they're probably, all of these other things are showing and they're in bad shape at that point. So get these people some oxygen and get them transported to a facility. Your book also talks about cyanides, caustic substances, hydrocarbons, and organophosphates as different toxins. The organophosphates, where is that poisoning going to occur in this area?
Pesticides,
Okay, so
like farms.
typically in the farming community, the farmers have a lot of chemicals, a lot of fertilizers, a lot of pesticides, a lot of insecticides, those types of things. And that is a poisoning that could occur in that environment. They have a nice acronym for organophosphate poisoning. The acronym is SLUDGE. It's on page 740 in your textbook if you don't know what it is. Essentially what it is every opening on your body will have something coming out of it. So the acronym stands for salivation, lacrimation, urination, defecation, gastric issues, and emesis. So things will be coming out of basically every opening on your body, your nose, your mouth, your eyes, and all other orifices. What is the fix for this?
Atropine.
Atropine. These people are going to present as going down the drain. They are going to be bradycardic, hypotensive, altered mental status, pulmonary edema, bronchospasms. They are going to look like they're about to die because they are. And the fix for it is atropine and more atropine. So in your case, if you come across these patients, you are going to need some medic assistance to give that atropine, because none of us are carrying it in the auto injector form for you to use. And I don't think any agency here has any kind of exception for AEMT to give atropine. So you can check with your local agency to see, but I'm not aware of anybody having that in place. So make sure you get some assistance if you recognize this type of problem. Food toxins. Good old botulism. How do we recognize and deal with that?
Isn't botulism like pretty certain death?
No,
Yeah.
can live from botulism.
They're going to present with gastrointestinal signs and symptoms.
Yeah. Vomiting, diarrhea, muscle cramps in the abdomen region, a sense of wanting to die because it hurts so bad and they're miserable. I like it. That's what they're doing. How do we fix it?
I would assume that we could give them fluids to help.
Yeah, we could. And that's going to be the thing. We're going to basically be managing signs and symptoms of these people. Pain management wise, not a lot of choices for us. If they're dealing with a lot of vomiting and diarrhea, then we have the justification for IV fluids to help with that. They need to flush their system. They need to get this thing in and out. So time it's going to take. They're going to be miserable for a day or two, and they'll get better. So watch out what you eat. It's not just the weird things, but it's how the food is prepared and how it's managed and how it's taken care of. You know, things that need to be refrigerated should be refrigerated at certain temperatures. If things are sitting out in the atmosphere for too long and then get refrigerated, they may be bad already. So watch out for that. If you go to these parties in the summertime and food is outside on the picnic table all afternoon that nobody ate, and then they stick it in the refrigerator and you eat it tomorrow and it was potato salad, you're probably going to get sick as a dog, right? So just be mindful of those things. Take care of yourself. Also be mindful of what you eat. These weird things that people eat now, they eat anything and everything, right? They'll pull off like specific tree barks off of trees and eat different mushrooms and those, you know, poisonous mushrooms and psychedelic mushrooms. And then there's actually good mushrooms. So you got to really know your mushrooms and your plants. And if you eat all these weird animals from Asia, you're probably going to get the coronavirus or something worse. So be careful about that and be mindful of it. There's a freaking fish that people eat that can kill them if it's not cut right. So why you would do that, I don't know. Number one, it's fish. And number two, why would you risk eating it if you know it can kill you? I don't understand. The book finishes up with the environmental toxins from animals and insects. So it's got all of the different poisonous snakes, and pretty much just about every one of them is in eastern North Carolina. So be mindful of that. All of the spiders are here. Black widows, brown recluses. We have copperheads, water moccasins, rattlesnakes. We have all of these things. So be mindful of those, especially with springtime approaching. Things will start moving again. So all those little snakes will come out of hibernation. The spiders will start crawling around everywhere. And with the mild winter that we've had, mosquitoes will be in full effect to carry on spreading disease and misery. And then the very end, it talks about medical overdoses, patients that maybe accidentally overdose on medications or purposely overdose on medications, and then the different classes. It puts them in a bunch of different classes. So you can look at the different classes of medications, and it ends with the recreational street drugs of cocaine, PCP, LSD, narcotics, marijuana, heroin, everybody's favorite, and those types of things. So if nobody's getting overdoses and wants them, come ride with Derek in Elizabeth City for a week. You will at least run, I'm going to say, a minimum of 3. If you work all of Derek's shifts for a week, you'll probably ride at least 3, right? What'd you say, Derek? If you're looking for those. Any questions about this information? All the openings in the head, the mental issues and behavioral issues, and then all of the toxins. Again, some of these have limited fixes for it. Others, we have some things that we can do. So we'll take those and do what we can. Labs this week, hopefully this works out. The plan is that Walter's going to go get the hearts and lungs and tracheas on Wednesday morning, and we will have them for the Wednesday night and Thursday morning labs. And he should have enough that everybody can have their own and play with it and do all those good things. So we're counting on that and hope it works out. What else? Anybody have anything?
Not that I can think of.
All right. If nobody has anything else, we're going to cut out of here. Study guide should be going up this week in the next day or so for the module exam, and then that will be occurring next week in the labs. For this week, finish out the last week of medical module. Make sure you get your online work done. Hopefully you're reading. It's a lot of chapters, a lot of information, so stay on top of that. And then if nobody has anything else, we'll see you in the labs Wednesday and Thursday.
All right. Have a good night.
All right, we'll see you. Take care.